Hi, everyone. We'll start in just a couple minutes. Thank you for joining on time. Rukai, I'm not able to see the participant list, so it's just you can because you're the host, but that's okay. Supriya, you're muted if you were going to say something.
We have about 19 to 20 people in there.
Yeah. But usually when you click on it, if you're the host, you can see the names, but it's not happening this time. That's fine.
Surprise, I can see them actually.
Okay. Well, you're more important than I am.
No such thing.
Thank you for those that are joining. We'll be starting in just a couple minutes. Thanks for coming in on time. We're excited to be with you here tonight. Okay, everyone, we'll give it just another minute or two for the last people checking in, and then we'll get started. Why don't you share your screen in the interim? Excellent. So everyone, good evening. I have 6 o'clock on my phone, which tells me it's time to start. And I always respect the people who do come on time so that we can actually value your time as well as everyone else's. So thank you so much for coming and joining us tonight. My name is Alan Kaplan. I'm a family physician in Aurora, and I'm the primary care central region lead, which means I'm the one who gets to nag you guys to make sure you're doing your screening and encourage you to do your screening for the better health of our patients in our region. With me is Dr. Kulkarni, our breast imaging lead, and I'll introduce her more in just a moment. Next slide, please. We're going to talk really about some new things in the Ontario Breast Screening Program, and I'm sure you're all familiar with this. When Doug Ford announced this, it was a big announcement. Is it a political thing? Is it a medical thing? And we're going to talk a little bit about that today. And we really want to talk about, from the point of view of primary care, expanding the Ontario Breast Screening Program to people age 40 to 49. And we're going to talk a little bit about informed decision making for those people because the risk benefits are a little bit different, and we're going to highlight those for you. And we also have some nice resources for both providers and the public, which we're going to share with you. Next, please. We are recording this, so make sure the comments you make are the ones you want recorded. And please turn your microphone off for now. We're going to have a question and answer period at the end. So there is a question and answer box up on the top or the bottom, depending on which version of Teams you have. And put your questions into there. The nice thing about that is you can see other people's questions and you can rate them up and down. If you have a technical question or a comment that's not a question, please go ahead and pull that in the chat, and we'll keep an eye on that. At the end, we'll go through those Q&As, and if people do have a verbal question they'd like to ask, we'll certainly encourage you to unmute and do that. We are going to send all the attendees a copy of the link for the recording, as well as any resources that we've created. And there will be an evaluation survey that Rukaya, who's our administrative support and works for CCO, and she's a fantastic resource. So thank you for putting all this together, Rukaya. I will send you in an email at the end. And again, as always, if you have any questions about this overall, or if you have any questions about screening, icsregional@southlake.ca is the email to send it to. Next slide, please. So even though we're doing this virtually, I think it's not inappropriate to talk about a land acknowledgement, although we're not really on land right now. We're in the internet, in the web. So the Central Regional Cancer Program is located at South Lake Regional Health Center in Newmarket, and it recognizes the lands originally used and occupied by the first peoples of the Williams Treaties First Nations, as well as other Indigenous people. And on behalf of the Central Regional Program, we want to thank them for sharing this land. We want to particularly acknowledge the Chippewas of Georgina Island First Nation. They're our closest First Nation community. We recognize the unique nation the Chippewas have with the lands and the waters of this territory. They are the water protectors and environmental stewards of these lands, and we do join them in these responsibilities. Next slide, please. So we're going to talk about the whole issue of early onset cancers, the expansion of the OBS program to people age 40 and 49. We're going to talk about informed decision making, the pros, the cons, and the decisions that people, the thoughts that people may have to have as they make a decide as whether or not to enter this program, and then those resources promised. So next slide, please. It's my pleasure then to introduce Dr. Supriya Kulkarni, who is our regional breast program lead. She's been in this program now for the last year and a half or so, and she's been a fantastic resource for me as well as many other clinicians in the area. In addition, she's the president of the Canadian Society of Breast Imaging. She's associate professor and breast division lead of the Department of Medical Imaging at the University of Toronto. She's a staff radiologist in Joint Department of Medical Imaging, University Health Network, Mount Sinai Hospital, Women's College Hospital. So I don't know how she does it in all these different places at the same time, but she does, and she does a great job of it. And I'd like to let her start off our discussion tonight.
Thank you, Alan, and welcome everybody. So Alan and me are going to go back and forth addressing different parts of the presentations just to, kind of keep everybody on their toes. And so I'm going to talk a little bit about early onset cancers, what it means, and that really lays the ground of why the program has changed. So early onset cancers are those that occur in less than 50 years of age, and they are associated with substantial morbidity, mortality, loss of productive life years, and have a greater impact on society and family. And we're going to see how that happens. Another definition is AYA cancers, adolescent and young adult breast cancers, which occur in the age group of 15 to 39. We are definitely seeing a shift in breast cancers in younger people. A lot more younger people are coming in through our clinics with breast cancer. And surprisingly, only about 16 to 17% of these AYA breast cancers are associated with gene mutations. We would like to believe that all of them are due to gene mutations, but they're not. So nobody really knows why this is happening. 9 times higher local recurrence is seen in these people after breast conservation treatment. So clearly they're at a little bit of a higher risk. They tend to have more aggressive biology, tend to be triple negative or HER2 enriched, tend to have LVI, which is lymphovascular invasion, and are grade 3 cancer. So quite aggressive in terms of requiring different types of chemotherapy. And because they are so aggressive, they tend to be detected at a later stage. They obviously have worse survival and inferior outcomes with treatment. This was published earlier this year in JAMA, which shows us, it's a very simple graph to understand, and it shows that there is increasing rise. There is a trend of increase in the incidence of breast cancers since 2016, 2017 in younger people from 20 to 49. This was published in the US based on their data. In around April, we also have this publication which showed a very similar trend of Canadian data, which shows us a similar trend of increasing breast cancer incidence in super young people. And if you look at this paper, which analyzed the Canadian data, it shows that the increase of incidence in breast cancer was noted as early as 20. There was about 56% increase in the number of breast cancers incidence in the women in the 40s, in their 20s, followed by the 30s, which was an increase of 12% since 1984, and in the 40s, about 9%. So we are definitely seeing similar trends in Canada that are being observed in other parts of the world. This is just an example to show you a palpable finding in an 18-year-old, and it looks very suspicious. And obviously, this was biopsied and it was an invasive ductal cancer. Here is another example, 28-year-old showing a really suspicious mass with some calcifications inside. And this is really very suspicious looking. And obviously, it was biopsied and confirmed invasive ductal carcinoma. Here's another example in a 24-year-old. There's an MRI which shows this really superficial, palpable mass. That's why the patient presented and shows like this typical ductal pattern, which suggests that this was spreading through the ducts. And again, this was an invasive ductal carcinoma. So we are seeing such presentations in very young patients. Why are we talking about them? There are some special considerations when we talk about cancers in this kind of age group, very young age group, because the treatment is quite impactful. It may lead to early menopause, sexual dysfunctions. There are a lot of fertility issues that need to be considered. People need to go for oocyte retrieval before they start their chemotherapy if they're planning to have children after their treatment is over. So this is a very different aspect of treatment, which is not a consideration in postmenopausal breast cancer. Young women tend to have younger children, and so there is a lot of emotional and scenarios related to families where there are these young children that women are taking care of. And also, the long term side effects of chemotherapy is quite significant. The cardiotoxicity, the chemo fog lasts for multiple years after the treatment is over. So, survival uh, phase is not really easy as we would like to think. And if you talk to patients, they'll say that it doesn't end with end of treatment. It goes on for much longer. Young breast cancer survivors also have a higher prevalence of psychosocial issues, anxiety, depression, significant concerns about body image, especially after breast cancer related surgery and treatment. And then, because these cancers tend to be more aggressive and diagnosed at a later stage, they may require treatments which are not covered through the the programs that we have right now. That leads to a lot of financial instability, workplace issues. There may not be enough health insurance to bear the cost of this extra treatment, and that can be quite debilitating to the families. And of course, we are still facing health disparity in immigrant populations, Black people, and people who are marginalized who may not have access to any of this. So there are a lot of considerations in this particular age group. And that brings us to the OBSP screening program and the expansion to people ages 40 to 49. So let's look at some evidence and policy making that has been provided by the program. Previously, the average risk program in the OBSP was recommended for the ages of 50 to 74. OBSP encouraged people between 40 to 49 to make a personal decision about breast cancer screening in consultation with their healthcare provider. And screening required referral for this age group. We've had many patients, even if considered anecdotal, who were denied access to screening because of their age group and ended up having more advanced breast cancer. So we have some examples. As of October 8, women, people who are eligible between 40 to 49 are included in the OBSP. This has gone live. The rationale for this was more equitable access. If should a woman want to screen, she should be able to enter the program. So self-referral was the biggest change that was offered as part of this change. It provides people who screen with the benefits of organized screening. There are always benefits of having a more organized and structured way of following people. Compared to the past, modeling results from the US have shown improved benefits to harm ratio for screening people in their 40s. What about in Canada? So if you look at this population data, you can see that about 13% of breast cancers are seen in the age group of 40 to 49. That's a significant number of cases. About 4% are seen in the younger age group, and we are certainly seeing more stuff happening here. And you can also, I would also like to highlight here that above 80 is also 13%. And it underscores the importance of offering screening to these women in the earlier age group. And also, if the patient is well and doing perfectly fine and has a longer lifespan expected, these women also benefit from extended screening. So here is what the program has done. They have conducted their own evidence for this expansion and have documented that there has been a slight increase in breast cancer incidence in women in Ontario in that age group of 40 to 49. Younger women are more likely to be diagnosed at a later stage. We discussed that. And we know that there are inequities in mammography screening participation, particularly in this age group. Those with no mammogram had a higher, are seen mostly in materially deprived communities, low income neighborhoods, and most ethnically concentrated communities. So, all of the stuff that we discussed, they found evidence that that is in fact true. Modeling results, as we discussed, also provided this information that there may be benefit. There is benefit in offering screening at the age of 40. And in the US, earlier this year, actually last year, the United States Preventative Task Force dropped the age of screening at 40. This is what we have from our own analysis that was performed, and it was seen that if you look at screening between 50 to 74 versus 40 to 74, so we added a decade here, there would be 4% more reduction of mortality due to breast cancer. There would be 1 to 2 more deaths prevented over a lifetime of screening, and there would be 519 more false positives, again, over a lifetime of screening, not every year. This is over a lifetime of screening, and we would have 2 or more cases that would be overdiagnosed, such as DCIS or any other low grade malignancy. When comparing starting screening at 40 to starting screening at 50, there may be, as I said, just summarize, small reduction in breast cancer death and mortality, a little bit more false positive, and a small increase in overdiagnosis. So this was what the program uh, came to a conclusion with. And as of fall 2024, this change was proposed and has gone into live into action now. We're seeing a lot of 40-year-olds coming to our clinics. So what do we have now? We have average risk and increased risk. This is not the high risk population. We are only talking about average risk and above average risk. The high risk program hasn't changed. It starts at the age of 30. So we're not talking about that today. So screening age is now 40 to 74. The modality of choice is mammography. The interval is 2 years, just like it was before. If you are at a higher risk, such as you have a previous diagnosis of high risk pathology lesion like ADH or ALH, any of such biopsy high risk pathology, or there is a history of breast cancer in the family, or there is extremely dense breast tissue, or if the radiologist recommends. So these are the scenarios where a woman will be recalled for a annual mammogram. So those are the few scenarios where people will come back every year. What are the criteria? Women, trans, and non binary people aged 40 to 74 are eligible to screen through OBSP if they have no breast cancer symptoms, no personal history of breast cancer, have not had a mastectomy, and if they are trans feminine, have used feminizing hormones for at least 5 years in a row. This went live last year, but now it's been extended to the age groups of 40 to 49 and have not had a screening mammogram within the last 11 months. This is very important, which means a woman could choose to come for screening every year if she would like it. But the suggested um, uh, interval is 2 years, unless they are at a slightly higher risk. So there are many changes that have happened for into the screening program. And Alan, this is where you take over, I think.
Absolutely. So really what we're talking about here is people who are learning about something new, about screening at a younger age. And that's going to be there's going to be a lot of questions from that, which is probably why you've joined us here tonight. There's issues with that. So the concept here is informed decision making, which means it's just not going to be prescriptive. We're going to tell people they have to have it or tell people they shouldn't have it. We're going to actually, make a decision with discussion between you and your patient. So the idea of that is healthcare provider supports the patient making a health-related decision by giving evidence-based information on options, benefits, and risks and outcomes. So therefore, that it's an individual decision for me. It's a personal decision to see if breast screening cancer is right for them. And the change here is the OBSP is now encouraging people age 40 to 49 to have that conversation with somebody. And we'll go through the somebodies it can be. It can be your primary care practitioner, it can be a family physician, it can be a nurse practitioner, or Health 811, which we'll talk about. So again, pros and cons of that. So the reason why the conversations are important compared to those people over 50 is because the overall risk of cancer is a little lower, and the overall risk of some of the complications that Supriya just talked about there in terms of false positives and so on are there. So we really want to emphasize that there are a little bit of differences there, and then they can make that decision. Let's move on to the next slide, please. So what you'll see here is that overall, next please. What you're seeing here is that this model, 40 to 49, really is not terrifically different than it was before. A conversation should occur here. Now you can self-refer, so that can be outside that. If you self-refer, you can just do it, or you can call Health 811, which is the Cancer Care Ontario's a whole bunch of resources in that particular line. You can go to your primary care practitioner, and there are prevention specialists available through Health 811. They can also self-refer. And then once they're in the program, the navigation of the program, one of the beauties of it is that there's actually somebody working with them to navigate that program and get through the difficult times. Next slide, please. So the concept here is calling that Health 811. So just calling 911, but you hit 811, and that's fine. And they don't have to have a primary care practitioner, or they can have one. They're allowed to have that conversation regardless. They may be able to give some more detailed information depending on the area about supporting the decision to screen. In case they don't have a primary care practitioner, they can get, or in addition to that, to give them some ideas. In addition, people are always concerned about wait lists and wait times and how to book an appointment. And these navigation specialists can actually help with that with wait times at different locations. One of the biggest barriers to invoking this program is training enough technicians to deal with the extra load, as you can imagine. And phone numbers for booking and appointments. And then the Ontario Health Contact Center for public to ask questions about general OBSP information. And then there's also mobile screening coaches. So if you need more information than that, it's available to you. Next slide, please. So what is part of this conversation that we're going to have with our patients? Are there benefits and harms? So again, this is trying to make sure that the patient and their family does understand that. So the benefits are clearly, as Dr. Kulkarni talked about, that we can find breast cancers earlier, and these younger breast cancers can present later in terms of course of illness. So we have a better chance of treatment working and treatment being successful. And obviously, if we can find something before it's a lump, before it's clinically obvious, there's a better chance that we can actually lower mortality. The harms, though, are that a test can sometimes be abnormal when it's not cancer. That's called a false positive. Some people will find extra testing reassuring, but there's actually been some data that shows the people that get false positive tests and go through biopsies and things, they become a little more reluctant, some of them reluctant to go through the process again. And I'll talk a little bit more about that later. In addition, there's the concept of overdiagnosis Dr. Kulkarni did talk about, and that's really hard because you found a cancer, but maybe that cancer is the kind of cancer that never would have become a problem. You all are familiar with that with prostate cancer. That's why there's so much watchful waiting done, because depending on the scale, it's something you can just watch. It's unlikely to spread and become a problem and kill people. So that's a really hard thing, because once you make a diagnosis, you're not going to ignore it when it comes to breast cancer. But these are one of the things you may find things that never would have been a problem. Next slide, please. So it's all about the particular values and preferences of the person you're talking to, and what matters the most to them about concern about breast cancer screening. What's been their experience? What's been their family history, which obviously will change their risk level? What's going to be their friends? What experiences have they had? What are they afraid of in terms of potential treatment, in terms of whether it be surgery or chemo or radiation down the road? So those potential harms and benefits are going to be colored by their own experiences, their own clinical situations, their family, and so on. So these are all things of the conversation you're going to have. Next slide, please. So for me, it's a matter of here's your choice. We've had the conversation. Here's the pros. Here's the cons. Here's your choice now. The only choice you have to make right this second as far as that is, do you want to be screened right now or not screened right now? So that's part important, not right now, not screening ever. It's not screening right now. So you're 41 years old and you say, well, maybe I'll wait till I'm older. Okay, but that doesn't mean that we're not going to have this conversation again. And certainly that conversation is going to have for sure at the age of 50 when you're going to start getting reminder letters to say, hey, it's time for this to happen for you. So it's not that you should not get screened at all, but if you want to decide not to get screened as someone under the age of 50, of course, that is your right. And that's the conversation you're having. Take the time you need. Right? And you can always change your mind and start screening. If you change your mind after the conversation today and you want to have it done, you let us know and book it, or you can just go ahead and call because you can book it yourself if you want to, and we won't be upset. But again, you will get that invitation starting at the age of 50. Next slide, please. So this came out of the annals, and I found this article, and I thought this is just to add to what Dr. Kulkarni had talked about later. And obviously, you get different numbers in different studies and so on. But in this trial, they looked at mammogram at the age of 50 compared to the age of 40, and they compared 1,000 women of each. And again, 519 more false positives, 62 more benign breast biopsies, much the same numbers that was shown there. There's psychosocial harms, there's anxiety that happens. You get a diagnosis of cancer. I don't care how strong you are, it's going to throw you for a loop. And even if that cancer ends up not being something that's going to be terrible, or that you have a completely successful treatment and a cure, you still have to go through a process. And even if it's a biopsy that ends up being negative, that's still a process and it's scary. And it can really change people's thought process. And I've said already that people who have false positives are potentially less likely to return for the next scheduled screening exam. Right? So another way to look at it, if you start at 40, there's a 40% chance of having at least one false positive. That's every 2 years. If you do it every year, and Dr. Kulkarni said, if you elect to do it every year, you can. The rule is you can't have it sooner than 11 months. But then there's a 61% chance of having that false positive by the time she turns 50. So the cost of that is in this age group where the risk of cancer is quite a bit lower. Yes, potentially more severe cancers. Yes, potentially missed cancers. But remember, we're talking about screening. We're not talking about someone comes in with a lump or a skin change. You shouldn't investigate it. That's not screening. That's case finding. It's a really important thing. We're talking about people that have no symptoms, no strong family history, no other reasons to be concerned. These are not high risk people saying, I just want to get it done because I want to get it done. And then if they go through these processes a few times and it's very traumatic for them, they may say, I don't want it anymore. And then we're talking about when someone's hitting 50 and 60. And Dr. Kulkarni showed the relative incidence of the numbers as you're getting older, the higher risk of developing cancers. And that's the age where it's really important to capture these cancers, or I shouldn't say really important, potentially more important because of the numbers potentially found, and they may not get them done. So there's the net harm that may occur as we sort of go through this thought process. Next slide, please. What I'm trying to do is sort of give you these ideas so you can have that conversation. The other thing, as you are all aware of, younger people tend to have more dense breasts than older people. And it's just a fact of life. And we all know that dense breasts trigger responses from the radiologist because poor Dr. Kulkarni can't use her X-ray vision to see through that lumpy one on the far right there to see what's underneath there. It's much harder to tell what's there. It's much easier. It's much easier to miss a lesion under that. So of course we're more concerned about that. We're going to be more conservative. We're going to recommend more imaging because you really can't see very much in that. So that's another whole population of people, and that's going to lead to more callbacks and more repeat visits and so on, which again is going to cause more consternation, anxiety, and so on. Next slide, please. So how can you personalize this particular risk of the person in front of you? So they're saying, okay, well, all right, well, I should have it, I guess, or I don't want to have it, or am I high risk or am I not high risk? Well, there are tools out there that you can use. So it's called My Cancer IQ, and it has cancer risk for multiple cancers. We're going to talk here about breast cancer particularly, but it asks about their medical history, their family history, their lifestyle, and it takes 15 minutes, if that, less if you're computer literate to do this. And you can complete this tool by yourself or with a prevention specialist using Health 811, or you can get this, you can just search My Cancer IQ website as a primary care practitioner, and you can find it there too. Next slide, please. So what it does is it creates a report for you that gives you an idea of your breast cancer risk level based on all these factors. It's broken down to lower than average, average, or higher than average, or high. And with that, it gives you a bit of an action plan saying, you know what, you should get screening and you should do lifestyle changes, or your risk is lower and you potentially could delay it if you want to do that. It's never going to tell you not to screen, but it's going to say your risk is small. So the risk benefit ratio is much lower for the risk benefit ratio is higher for you if your risk is smaller. So next slide, please. So have a look at that My Cancer IQ site. I think you'll find it interesting. Play with it for yourself personally, just to get an idea. And then this is a resource you can go through with your patients. Now, there are resources about this entire process that Cancer Care Ontario has created. There's resources for both us as providers and also for the patients. So there's a provider tool to support these breast screening conversations. Obviously, this education program is one of them, but there's also PDFs of this. There's a whole document of frequently asked questions there for you, and there's website updates that are going to be happening continuously as we go through the processes and make the changes that Dr. Kulkarni had mentioned. For the public, they can look this up as well. There's website updates. Go back just a step, a little too fast, please. We've talked about My Cancer IQ, and there's a particular breast screening information sheet for people aged 40 to 49. That's just being finalized right now. It'll be on the website soon. Now, please go ahead. Thank you. So the tool for us a little bit more again is have the conversation we've just had here tonight, talking about the breast cancer screening conversations, about the risk, personal risk, the pros and cons of it, the benefits and the harms, and what matters to them as part of their health. And yeah, just a couple more there. So on this website, you'll see the frequently asked questions that I frequently asked and therefore answered questions to help you, because what comes up to you may be unique, but probably someone else has asked it already, so it's there for you. And we're going to continue to update these Q&As, and we've updated them. They've been there before, but now we've also updated them for the age 40 to 49. And next slide, please. Again, we've talked about the web tool already, and we've talked about OBSP site locations. That can be a big deal, because when someone actually decides they want to get the screening done, they're often, when they decide to do it, I want to do it like yesterday. I don't want to wait months and months for this. So these location and site wait times can actually can help them actually get a test done a little sooner. Maybe it's a little further from where they live, but so on, it can be helpful for them. So it used to be an OBSP locations page. This has replaced that. So you're able to find out how to contact them, languages that are available, which can be a barrier for some, timelines, accessibility for people who have disabilities, wait times, and of course, you can book your program yourself. So let's talk about next steps, Dr. Kulkarni.
So that was a lot of information, Alan. I'm sure people are going to have to go through the whole thing again, and there are a lot of questions. So I'm going to try to keep it brief so that we spare some time for the question answers. So there is obviously going to be a phased approach to expansion. This is the most critical process of the program, and it is in place now in 2024. The updated program policies, the new program elements, prevention specialists, and strategies to expand the system capacity. There's a lot of work happening, and there is a lot of discussion happening at the regional cancer programs to accommodate this expected increased volumes at each site. The other enhancement includes implementing correspondence. We're going to touch upon that a little bit in more detail. So at the current time, when the program was for 50 to 74, this is the correspondence that all women who are in the screening program get. The normal result letters, the recall letters, when it's time to come back for the next mammogram, they get reminder letters, and they also get invitation letters when women turn 50. So this has been in place for many years. What's going to happen to the new age group that we have added? So the program has made this change, but all the changes for correspondence are not in place, and it will be implemented in a phased approach. And it's very critical that the referring physicians do understand what is going to reach the patient and not. So this is just a simple chart, which is I've just divided into 40 to 49 and 50 to 74. This has been in place for the longest time since the program has enhanced. So invitation letters. So when a woman turns 50, she automatically gets a letter. This is not going to happen when women turn 40 yet. So this is not going to happen. So nobody is going to get automatically invited into the program. So women need to find out that the fact that they can be in the program either through some social media approach and some like from their family physicians. And the program is actually tracking this information. When women come to screen and they are in this age group, they are being asked, how did you find out that you can come for screening, and that is being captured as a information in the program and to be used for promotions at a later stage. Normal result letters. Patient comes for a mammogram, the mammogram is normal. All of them will receive normal result letters. This was happening before. It is also going to happen to women between 40 to 49 when they come for their screening. The result letters include these three things. One is the result, that there's nothing found on your mammogram. The density, A, B, C, or D. Women are going to be informed regardless whether they have dense tissue or not. So all of them will have that information. And there will also be a note to suggest that you should return in 2 years or you should return in 1 year. So this letter is going to go to everybody who has screening within the OBSP. Abnormal result letter. This is per current OBSP. Nothing has changed. So the program never sends anybody an abnormal result letter that, oh, you need to come back for more views, you need to come back for an ultrasound. That is something that the site performs. So if the patient has a mammogram in South Lake and requires to come back for more views, it's the facility which will contact the patient. So that has been in place for the longest time. So the OBSP is not involved in bringing patients back for additional workup. And so that's not different for the new age group. Recall letters, women between 50 to 74 will get a reminder letter that you are due for your next screening mammogram. Women between 40 to 49 are not going to get it as of now, but that is one of the first things that is on the list to be included in the program. So I'm hoping over the next 1 year, we will see some changes happening. But at the current time, if a woman has the first mammogram, she will not receive a letter to come back for her second mammogram. So that is something that the patients need to understand when they get their results. They will get a normal result letter, which will tell them when to return, but they will not get a recall letter saying that it's time to come back. So that's the difference. And they are planning to roll this out soon. I don't know when. Nothing else has changed. If the patient has a BIRAD 0, which means an abnormal result, it's the facility which will call people back. OBSP does not send any communication around that. The PCPs are responsible for this, or the referring physicians have to follow up on what happens to this. If the patient needs a 6-month follow-up, like 6-month follow-up mammogram, 6-month follow-up ultrasound, that is per current OBSP standards, wherein it is not the responsibility of the program to bring women back for a 6-month follow-up. That responsibility still lies with the referring physician. So that has not changed. So this is just a snapshot of what is going to happen and how it's designed at the current time, and we are expecting some changes. So as of now, women who are average risk, 40 to 74, will have a mammogram once in 2 years. If the patient is a woman is at increased risk due to any of these conditions which we discussed before, she will be recalled for an annual mammogram once every year. And a person who is high risk, the program is in place, nothing has changed. This person will come at the age of 30 and will have an annual mammogram and MRI. And if the patient is unable to have an MRI, they will have an ultrasound. So that hasn't changed at all. Centralized correspondence, we discussed this for the 40 to 49 yet. There are a few changes expected, but I already showed you a chart as to when people will receive a letter if they are 40 to 49. They will all get normal letters, but they will not get further invitations for additional screening subsequently. These are the resources. The websites have been updated. There's a lot of information. My Cancer IQ is a very easy tool. I tried it myself. It did not take me 15 minutes. And the 811 tool is really good. The screening wait time and location tool has been used by many women, and we have received in other regions a feedback that's been very useful. So is this your part, Alan? You're muted.
Thank you so much. I just wanted to add that My Cancer IQ includes risk for breast cancer, cervical cancer, colorectal cancer, kidney cancer, lung cancer, as well as melanoma. So not just the ones we're screening for currently, and lung cancer is coming to our region not this year, but probably 2026 to my disappointment, but that's going to be when we start. And we'll be having lots more conversations at that point. Right now, if you're interested in lung cancer screening, you could send people down to UHN from our region, but that's a conversation for another time. We want to move on to the next slide though. And yeah, back one, please. So all this time, we've been getting a whole bunch of different things that giving us reports on how we're doing as far as our screening. And what has happened, and one of the strengths that have happened, and this came as a result of Cancer Care Ontario recognizing what the regional leads were saying from across the country, saying there's too many different sources of information, and it's confusing to use your screening activity report that you have to log in for, to use your practice reports that you get also separately into your email. So now they've actually put it all together. And you do have to log in to get it. You have to use your one ID number to get it. And yeah, that's kind of a bit of a pain. But once you sort of get your number, put it there, have your computer remember it, then it's not so hard to actually go in and out all the time. I do an e-consult service and I have to log into that every single time. So it's now pretty quick for me. So it used to be something that I hated, but now in fact, it's not a really big deal. You get your data across a whole bunch of things, including things like diabetes and antibiotics and opioids, but also in terms of your cancer screening. So all of this information is in one place. Next slide. And there's going to be some trainings webinars. They're very soon, like tomorrow and then a couple of days later for that. And we have sent you a link, so sorry if it's last minute, but if you're interested in doing that. The value here is you can actually, by looking this up, you can actually see how your practice is in terms of screening. Now, I know that we're not getting paid our bonuses for screening anymore, and that takes away some of the incentive for some of you to do this. But really, that if we don't screen, who's going to suffer for this is your patients, because we're not going to make a diagnosis at a time potentially where we can save their lives and make a huge difference in them. So there's also learning modules about this new resource to be able to look up your screening rates available at the website there, cancercareontario.ca/en/primary care reports. But we'll be sending you all this. You can look all that up. So next slide, please. So I thought I'd summarize here for the two of us, saying that we now have this edition of OBSP screening for 40 to 49. It's been the subject of debate for a long time. This issue has been pushed by a variety of different groups. It got approved in the States first. There are certain populations, again, we look at My Cancer IQ, it captures that, but the data, interestingly, in the United States, that black women tend to have cancer younger than white and Asian or somewhere in between. So, I mean, there is differences here, and Dr. Kulkarni talked about the genetics of this, but it may be more than just the genetics. There may be socioeconomic things. One of the articles I read about microplastics may be a factor here in both brain disease as well as cancers. There's all kinds of things that we don't know. But the bottom line is that younger cancers are occurring across the board in all the cancers we're dealing with. And now we're just dealing with this with breast cancer right now. We've talked about the pros and the cons. I hope they're clear for you and you have an idea of how to discuss this with the patients. If not, these things can be reinforced by the resources we've talked about. Patients can and will self-refer, and I say can and will because then you're going to get reports from their self-refers and you're going to have to still deal with them. You're going to have to have conversations and counsel people through these things. High breast density, I think, is going to lead to more recalls. So in the conversations you have, you say, well, one of the things that's going to happen because your breasts are going to be thicker than some as you get older, we're probably going to have to do some more imaging because of it. So don't be alarmed by that. It's just a factor of looking at younger, thicker breast tissue. But with all this, I hope you're ready for this, and I look forward to your questions. There's none in the Q&A box there right now that I can see. So feel free to put some in there now, put some into the chat, or if you'd, actually there are some there. I'm sorry. So Alex, how are you? Based on your slides, is there evidence to advocate screening age 30 to 39 years old? Dr. Kulkarni, why don't you take that? Because I think you dealt with that with a high-risk group.
What's the age? Let me see. What's the question?
Is there evidence to advocate screening between age 30 and 39 years old?
No, not for average risk, for sure. It's too early to offer any kind of mammographic screening in that age group. But if they are high risk, then definitely, yes, the program starts at 30. But younger than 40, there is not enough evidence to suggest that they should get screened regularly.
Yeah, Alex, you saw the relative incidence of breast cancer in that younger age, and it's very, very small. So it's not that some won't be picked up. We just don't know if we're picking them up at a more severe level, or more importantly, whether making the diagnosis early is going to make any difference or not. So there's a whole bunch of factors in that. But for the very high risk, the strong genetic risk, that's different.
And that is bringing back like this discussion around breast self exam. I don't want to open that can of worms here, but like this is going to come up now because we are seeing cancers in younger women, and what can we do? We can offer them regular mammographic screening. So what are we offering them, right? So that's that.
Sorry, so Supriya, what are you actually saying, that they should be examining or not
Oh
examining
God, I don't.
cancer?
I'm like not the expert
You brought it
in,
up.
but it was a question that came up in
Yeah.
another forum, and so we call it like one should be breast aware. People should know how their breasts feel. Does that mean they should be examining it every day, every month, once in 6 months? I don't know, but it's good to be breast aware.
There was a study done a number of years ago, and I'm sorry I can't remember exactly, but it was long ago, long ago enough now that some of you might remember. And there was a study that showed that people who examined didn't have better outcomes that didn't examine.
Yeah,
And based on that fairly small numbered study, there was a front page thing on the newspaper that says you shouldn't examine your breasts anymore,
yeah,
which
yeah,
I think is preposterous. I think there's a
yeah,
point in doing it. How often to do it is a good question. What's the best
yeah,
timing of your cycle to do it? Because obviously, towards the end of your cycle, you're going to be more swollen and have more cystic things and so on. So these are all things you're going to talk about and you're going to converse to your patient. But
yeah,
I think if someone wants to examine, I think they should, but they shouldn't be examining every day. That's going to make somebody old in a hurry. All right.
yeah.
Next question, Hoda. Thank you. Who will follow up with the patient who self-referred to the program and does not have a family doctor? Well, I guess I'll take this one because that ends up in my bailiwick. So, most of our OBSP sites have a clinician who's agreed to take on those abnormalities and will contact the patient and help them through the process. When those persons not available or a site does not have one of those people, then the job comes to me. So as a regional lead, so I get all the unattached patients for all the different cancer screens that are done, be it breast outside of the OBSP that have one, and colon and cervix and so on. So that comes to me, and then we arrange to see them and get the next follow up done.
So every OBSP site needs to have a designate physician. So if they don't have, if a patient doesn't have a family doctor, as Alan pointed out, is the report will go to the designated OBSP physician. For any facility to be approved, they have to have a designate. So there should not be a problem with people. Some people have nurse practitioners, whatever it is, like the specialist, but there should be someone.
Yeah. Now, if anyone's interested in being involved in this process as an OBSP designate or part of a family health team, or just if you're fee for service and want to do this and you're interested in actually seeing these patients, then I'd love to help. Frankly, sometimes it can be a fair number of people. Usually, it's not very many. But anyway, if anyone's interested in seeing these people and helping them through the process and building up your practice that way potentially, please feel free to let me know. Alex also asked, can you phrase it number needed to treat versus number needed to harm in screening people? Alex, right what you wrote there, it said in screwing. I know that was a typo, but in screening people aged 40 to
I hope
49
it
years
wasn't.
old.
I
I'm
hope it
sure,
was.
I'm sure it was. Has anybody worked those numbers?
There are numbers, but I don't know. I can look for them, but I know what you're asking. I don't have the exact numbers.
Yeah, I perhaps could do some division on that to see what the numbers are. You basically divide it
Yeah,
one over that number and you get the idea, but
yeah.
I'm a little too math challenged the second to do it. So I'll move on and maybe Dr. Kulkarni will do that while I'm reading. So the discussion is about age people 40 to 49, but the question from Sephora is, what about people over 74 who've had normal mammograms all their life, no family history, but they're on HRT and want mammogram?
Yeah, so I already mentioned that when I was showing you the incidence. So women between after 74 also have a 13% likelihood of 13% incidence of breast cancer. So if a woman is well, healthy and no comorbidities and wants to get screened, they can still be screened through the OBSP, but they require a requisition after 74. It's not a self referral anymore, but the program will allow women to stay in the OBSP program. They will require a requisition, and it'll be once in 2 years. That hasn't changed.
So everything else in the program is the same, as you say. It's just you have to write the requisition for them because
Yes,
they won't be able to do it. Are they able to self-refer? I don't think so,
they
right?
can't. No,
Right,
they cannot self
right,
refer.
right. So that's the difference, is there has to be a clinician who's deciding it's worthwhile. And I think if someone's on hormone replacement therapy systemically, not vaginally, I'm talking about, or so on, but if they're on systemic, I think it's probably not a horrible idea to be doing that. I think it's a safety thing. So overall. Okay, and Matt said even age between 40 and 50, breast density D category, do they need annual mammograms? I guess he's had some report, he or she's had some report mention next one 2 years for those with higher breast density category D. So what would you say to that?
So if the mammogram is categorized as category D, the program will automatically call women back in 1 year. So they're right now, like I said, patient won't get reminder letters, but when they get a result letter, it will explicitly say that you should have your next mammogram in next year. So once every year. The report, the radiology reports, probably they're just using the same templates and haven't updated it. If you want, you can share one of the reports and we can reach out and adjust that. But density D program will automatically suggest annual screening.
Yeah, actually, Matt, I would actually encourage you to do send that to the team. Rukaya, maybe you can reach out to him because that they may actually be making an error that they don't
Yeah,
realize they're making. They may be using an old report and so on. They haven't
yeah,
updated their
yeah,
template,
yeah,
and we have to let them know if that's the case because if it really is D, they should be doing it annually. Because as I showed
yeah.
you the picture, you can't see through that. It's like looking through concrete. So we need to be doing more screening for them.
So there are some in the chat. If you want to
Okay.
go there, Alan.
All right. Okay. So for the people who complain of severe pain with mammograms, what would be the minimal advice to give for frequency of mammograms?
The frequency of mammogram is based on evidence, not on like really patient experience, unfortunately. So the newer machines are much better at to providing comfort. The compression paddles are more are made in the shape of the breast that minimize this the discomfort. And it is like, to be really honest, it's not the best experiences to have a mammogram, but it's very transient. So we like to encourage people to have a mammogram. What you can suggest is that they can have it in the post menstrual phase, like after they've had, like between the 7th to the 13th day of their menstrual cycle, where there is minimum congestion, less progesterone and estrogen effect on the breast. That usually allows the compression to be less painful. So that's something you can encourage and talk about with women who have, particularly women who have very tender breasts and cyclical pain with their menstrual cycle. But pain does not change the frequency of mammography.
No, just the inherent desire of the patient to have it and the inherent desire of the patient to not, the doctor not to argue with the patient. We get that.
Yeah.
I mean, I say the same thing in terms of timing. Just like we give someone an Ativan before an MRI
Yes.
if they're claustrophobic, I say, well, take some Advil, assuming you
Yeah.
can take an NSAID. Take some Advil. I mean, potentially, I've even given a couple people a diuretic to try to bring things down. That's a little bit extreme, but if it's the swelling seems to be part of their problem, I'll even try that for a couple people, just to sort of make that little bit of a difference. But yeah, that's it's one of those conversations you have motivational interviewing with the reasons you want to have it, the reasons you don't want to have it, what's important to you, and if the pain is more important to them than prevention, you probably won't have much success in the conversation. But
Yeah.
I think overall we have to give them the other side of the conversation, why it's important to do that for them. So a question here: are routine breast exams by physicians recommended in family practice? Some patients ask for it during pap smears. So as Dr. Kulkarni is a radiologist and isn't examining a whole lot of people other than when she's doing it for testing, I'll try to answer this. I mean, it's funny because in those years where the recommendation was not to do breast self-exams, does that mean that the doctor shouldn't examine either when you have somebody there? And of course, it's completely random when you might be examining somebody. So, do I do breast exams when I do when we had annual physicals? A whole other thing because the government doesn't pay for those anymore in Ontario. Did I do them? Yes. Did I find things? Occasionally. Yeah, I did. I can't say I never picked up something, did, because I did. It's a random way of doing it though. So while I would doing it during an exam, because sometimes patients, as you said, you should have expected it, I would have the conversation about them doing this once a month and getting into a habit of doing this because they're more likely to pick it up the 11 months a year or the 35 out of 36 months for the between pap smears or so on they might have. They're more likely to pick something up than waiting for me to do it. So that's why I did encourage people to do their exams on their own. And did that cause some unnecessary visits? Probably, but I'd rather have an unnecessary visit and reassure it's not a problem than miss something earlier. So that's my answer to that. You showed it, but I think you probably asked 20 people, you're going to get 50 different answers, but that's the best I got for you. Okay,
So the
any
next
other?
one is, there's another question there.
Oh,
I have
okay.
a patient who's more than 50 years of old with history of thyroid cancer. Her mammogram was normal. I have the impression to repeat in 2 years, but she received an invitation for screening in 1 year. Does she need a annual mammogram? So if the OBSP has called her for the annual mammogram, there is something clearly that was flagged. Maybe her density was D, or there may be some other risk factors which has flagged. So if the OBSP calls her for an annual mammogram, they are pretty good with finding these patient can have an annual mammogram, and if she doesn't want to, that's totally her choice as well. So yeah, so just check the density and see what the density was. All mammogram locations include in OBSP program or only specific locations. Usually, majority of the facilities that have mammography will be OBSP authorized centers. Patients can always check online. The tool that Alan mentioned, people can literally put their postal code, and it spews up like a list of clinics in their postal code where they could go and have screening. But yes, OBSP screening mammograms should be performed at a designated center. There are many people who can get screened outside the program at other places. That's also possible, but if it is always better to be in an organized screening program. So patients can put postal codes and find out locations.
I want to reiterate that point. Yes, you can get mammograms in sites that are not OBSP compliant. The problem with that is then every single step after that you are responsible for as the clinician. So I can tell you that when OBSP first started, going back 40 years ago, I wanted to keep track of everything myself. And I said, no, I don't need people in the program. I can do it myself. And what I realized is that, first of all, it's a lot more work. Second of all, I wasn't doing the job properly because some people were falling outside of my net. So the nice thing about this is they're going to contact people, they're going to invite people again if they're in the once they're in the program, they're going to follow up results and they're going to keep you copied. And it works seamlessly most of the time. Nothing works seamlessly all the time, of course, but it works seamlessly most of the time. But if they are doing mammograms outside of the process, then it means you're responsible for everything. You're responsible for telling them it's normal, that it's abnormal, for follow-up, and you're not going to get help from that particular program because it's not part of the program. Whereas even getting appointments and stuff can be helped by the OBSP program itself for follow-ups. And we do track that very carefully. So one of the things we track is how soon after an abnormal mammogram we go to a biopsy. We keep track of that stuff, and we're on it. And if a site is too slow or so on, then we're looking into why that's happening. Is it the site? Is it the practitioner not organizing something sooner? And so on and so forth. So these are all things that we look at. So my advice is if you're doing screening, then you should do screening as part of a program. And I'll go off topic a little bit to lung cancer because many of you may be ordering your own CTs, but that means you're responsible for everything that happens with that CT afterwards. So I think you should try to be part of a program that's going to make your life easier, and it's going to probably end up, other than some inconvenience maybe for distance, it's going to be better for your patient. And then Adrienne asked the question about getting an appointment at the right time of the cycle is going to be difficult. What I do in those circumstances is I actually get the person to actually call and explain that they needed a certain part of their cycle and try to get it facilitated. But in addition, we've already mentioned that they can actually go to a different site where the waiting list is shorter. So they can do a little bit of shopping. They really can, and shop for the site that works best for them.
Although from a radiologist's perspective, it's nice to stick to a site.
Of course,
if it's because we need prior comparison. So that leads to a whole bunch of other false positives if we don't have the priors. So
well, they should keep going to that same site after they start going there. Yeah.
And yes, it's very tricky, and sometimes people are able to call the sites and adjust it by a couple of days. There's always some spots that can become available, so closer to date. We have this problem all the time with the high risk population because we want them screened in a specific phase of the menstrual cycle. So the facilities are able to have a little, leeway to adjust for an occasional patient. So just talking to them is better.
There's another question in the chat. Hi, Dr. Kulkarni. Please comment on breast implants, breast imaging, risk of implant rupture with a mammogram, breast MRI need.
Oh, I don't see that. Anyways.
Yeah, me either.
It's at the top.
It's right at the top. Maybe I missed that. Okay, so first of all, everybody with implants is also eligible now in the OBSP program. That went live last year. There is no evidence that mammography causes implant rupture. So we should have them have the mammogram. It's done in a very different way. The view that is obtained with the implant compress is a lesser compression view. So it's not as tight as a normal mammogram. And then we have an implant displaced view, where the implant is actually pushed out of the radiologic, like the imaging field, and the remaining tissue is compressed. So there is no risk for implant rupture. There are certain types of implants which I recently came across. They're called high profile implants, and those are really large implants, and they're placed in women who want to augment their breast size beyond, like, what one should have or whatever. But they're called high profile implants, and when you have such a large implant, it's impossible to displace the implant out of the field, because the whole breast is occupied by this high. And so I was talking to one of our breast surgeons at plastic surgeons at UHN, and he said in those women, sometimes, it's been recommended that they can't have a mammogram because the implant is so huge that the mammogram is practically useless. Mammogram is a compression technique. You can only get a good image if you can compress enough. So there are very specific types of implants where patients may not be able to have a mammogram, but otherwise there is absolutely no risk.
And they're eligible for the OBSP program now,
They are eligible
which
for
is a
the
change.
OBSP.
Yeah, that's a
Yes,
change last year, so that's
they're
important as well.
eligible. They're eligible for high risk, average risk, and above average risk, everything.
And the other question that was there, I see it now, I found the spot, thank you, is why don't we screen after 74, since they're a fairly large group, and that's not considered old anymore.
It is. We address that, right? We address that.
But they're not part of the program. So we said that they can be screened, just you have to write the requisition for them. But Carol's question, maybe why don't we include them overall into the process and go through and include them? And I think a lot of that, and again, I'll speak first to see what you think about this answer, is that a lot of people over the age 74 are no longer otherwise fit for screening, for cognitive issues, for other medical conditions that maybe screening is not in their best interest. So it's not sent to everybody at 74, but individually, if you think a person in front of you is well enough medically and otherwise to go through this process, then you can arrange it. I think that's probably the answer. Dr. Kulkarni, is there anything else that you know?
No, that's true. If the patient is certainly doing fine, and which they are, we're getting a lot of women in the 80s also, and they should have a mammogram if they're able to. But if there's like comorbidity, something else, they're like, there's mobility issues, they're in a long-term care, or like if there are comorbidities, then you have to balance out the benefit versus harm.
Yeah. And if we're to send all those people letters, then there'd be a conversation about why not, and you may have issues. So I think the decision was really made that at a certain age, we're going to make it sort of, you can still do it, but it's more elective to have discussion with your clinician rather than being driven by the program. Well, it's 7:00, everyone. I want to thank you very much for all your questions. Some fantastic thoughts there. I hope it's clear now how to approach these patients in this age group and the pros and the cons, and with the resources that are available to reinforce what we talked about. I want to thank Dr. Kulkarni for the amazing talk that she gave to really clarify these issues. I want to thank Rukaya for arranging everything. And let's take care of our patients and prevent what we can prevent, everybody. Have a great night.